Welcome everybody. First item on the agenda is urgent business. Do we have any urgent business?
None received, Chair.
Appeals?
None received, Chair.
Does any member have to declare any interests? And item 4 is the minutes of the meeting held on the 26th of August. Can we agree those as a correct record? I see David Regan nodding, or Dennis is nodding as well, so we'll take that as approval, and we'll move on to item 5, which is the COVID-19 update. So I'll hand over to Director of Population Health, David Regan.
Thanks, Chair. And Andrew, could you bring up the presentation, please? Yeah, so you've all been sent a copy of the updated 12-point plan. I say updated 12-point plan. By the time the paper was issued, some of the information was already up to date, and so I'm using this presentation just to make sure you have the most up-to-date information to hand. I think it's fair to say that since we last met in August, as you will all be aware, we've been through the second wave of the pandemic. We are coming out the other side of this, but there are still some obvious challenges to us all, as you'll see and hear about shortly. But clearly, going back to early January, when I think I had the first meeting at North Manchester General Hospital in mid-January, when we'd heard about some of the information from Wuhan, it's worth reminding ourselves just about the amount of effort and work that's gone in to managing COVID in our city over the last year. And I think, as you'll see now, when I move on to the next slide, I'm going to start with some relatively good news. When we look at our headline rate for the city, it's now down to 164 per 100,000. We're ranked 5th in Greater Manchester. And importantly, our over 60s weekly incidence rate, because this is the rate we look at, because we know if this is high, it'll translate into hospital admissions and pressures on our critical care capacity further down the line. So this has been coming down over the last month. We are still, unfortunately, ranked 3rd in GM, but our rate has come down now to 189.7. And then our positivity rate in terms of Pillar 2 tests, the proportion of positive tests compared to the number of tests undertaken, is now down to 5.8%, and we're ranked 6th in Greater Manchester. Just worth reminding ourselves that back on the 3rd of October, we had the highest headline rate of any area of the country, 583.5, and we've seen a significant downward trend in the past 10 weeks. And then, as I've already mentioned, the welcome decrease in the over 60s rate. And I think the next two graphs just highlight these reductions. So next slide, please, Andrew. So I know this will probably be quite faint, but I think you'll all be able to see very clearly the yellow curve. It's definitely a spike. You can just look at it visually. That was related to basically the student outbreaks in September and October, and have to give credit to our university colleagues, both universities, for the collaborative work we did together with them, the council, our NHS partners and the universities, to manage those outbreaks quickly and effectively. You can see how quickly those student numbers came down, which then had the positive benefit on our headline rate of helping to bring that down. And then the other lines underneath are the different age bands, and you'll see not as sharp an increase, but you can see the beginnings of the second wave, and then that gradual decline that we're seeing across all age groups in the city. Next slide, please. Now, this is an interesting slide, and something that we're now going to report on regularly. When the government looked at the 5 sets of indicators to determine the tiers, one of the indicators was the rate of reduction in your over 60s rate and your headline rate. So again, just to explain, the visual nature of this. The blue bars at the right-hand side of this graph are the percentage reductions in that headline rate of the over 60s that we've seen. It's comparing 1 week with the previous week to see percentage reduction, and obviously under the line, the bars under the line, the bigger the bar, the bigger the reduction. And as I say, certainly up until a few weeks ago, we were seeing significant percentage reductions. Things have slowed slightly, but the important thing is that headline over 60s rate is still coming down. Next slide, please. So there's a lot in the 12-point plan. You'll see that we've got 12 distinct programme areas of work, and point 2 of the plan, there's a general reference to our testing programme. We've been obviously delivering our testing programme through our testing sites, the regional testing sites at the Etihad and the airport, and our local testing sites. Central Retail Park, for example, Denmark Road, have all been delivering the PCR test. What we will now be doing in the coming months is, you'll have all heard about the Liverpool mass testing pilot. Building on that, we are going to be looking at the best use of lateral flow tests, so the test where you get a quicker result within 30 minutes, and where you don't have to send the specimens off to the laboratory as you do for a PCR test. So we've already got some lateral flow testing programs in the city. As I speak, both the trusts, our MFT colleagues and GMMH have been delivering lateral flow tests to frontline staff. And we've also, the final day of today of our university lateral flow test programme with both universities. I think they're approaching now 10,000 tests, just waiting for the latest data flows to come through. And so far, only 30 positives. So again, evidence that the student outbreaks were managed, and the numbers of students with COVID are relatively low. And the point of this programme was to test our students before they went to their family home or parental home for Christmas. And clearly those students, although there are only 30 of them who've had their positive results, will be following the appropriate advice, and it will make sure that they don't go home or knowingly infect other family members on their return home. We have one school involved in the National Schools Pilot, which finishes on the 18th of December, and this is just testing out the best approach to school bubbles and how you would get a more pragmatic, proportionate approach when we come back for the next school term in January. But the results of that pilot won't be available. It's a national pilot till after the 18th of December. And we've just been invited, and we're doing that today, to submit our own plans for a targeted testing at scale community programme. And we're completing our submission today. Greater Manchester had put forward a submission, which was well received, but actually they've asked for each of the individual local authorities to now submit information. So Manchester and Oldham have been asked as the first group of Greater Manchester authorities to submit their proposals. We're working on those as I speak. We'd already done a lot of the preparation. You'll see in Appendix 1 of the 12-point plan some of our thinking and our approach. But I do want to emphasise the priority for us of this testing programme will be in relation to care home visiting. You'll have seen a lot of media coverage about this, wanting to make sure that family members, carers can visit their loved ones in our care homes in a safe and secure way. And what we're doing in Greater Manchester that's different to the rest of the country, and it's based on the expert advice of consultant virologists in the city and others, is proposed that prior to visiting the care home, we're asking carers or relatives to take a PCR test at one of our PCR testing sites at least 3 days before the visit. Depending on the result of that test, clearly if it's positive, the visit won't happen. But if it's negative, then on the day of the visit, we're asking them to do one or two things. Either take a lateral flow test at a care home, where the care home is able to offer that service, or where the care home isn't able to offer that service, to actually direct them to hopefully a lateral flow testing site that we will hopefully have operational from Monday. Can't really say any more about that at this stage, but we're planning for that contingency so that no visitor to a care home is denied access because the care home hasn't got the facilities to offer the test. And clearly we're working with our care homes. This has to be managed really, really tightly. The overriding aim is not to introduce COVID into a care home. And I think obviously care homes and the visitors understand that, but a really important message. Next slide, please, Andrew. And another very fast-moving programme, and it's great to see so many of our GP colleagues on the call for the Health and Wellbeing Board today, because we know you're centre stage for the delivery of this programme, and you'll probably know even more than me as I'm running through these key points. But we all know the Pfizer vaccine was approved on the 2nd of December, so earlier this month. And we also know that the first person to receive the vaccine in Coventry, we saw that on the news yesterday, a really great occasion. And I think all those involved in public health, it was a real landmark day. We also know the AstraZeneca vaccine, which is cheaper, easy to store, easy to administer, is at the final approval stage. We know that the Lancet article this week was very supportive of this vaccine, but we also know there's a need just to look at some additional information. We know that by accident, through the trials, the half dose followed by a full dose resulted in better efficacy, over 90%. So really welcome, but I think clearly just some more questions being asked at the final stage of the approval process for the AstraZeneca. And then the Moderna vaccine, when I think of this, I just think of the Dolly Parton contribution to this, will come online next year. We think this will be a bit later in the pipeline, but it will be obviously very welcome as well. We've moved very quickly in the city to establish a project management office. You'll see in the appendix 2 of the 12-point plan. I'm the SRO for the city, but Dr. Manisha Kumar is the clinical SRO lead, and we've got an excellent team, our LCO colleagues, everyone really behind a very well-established formal programme now. And we know we will be moving very quickly before Christmas now with delivering the vaccine. So we know about the plans to have vaccination sites that will cover all 14 primary care networks. We know a number of sites will serve more than one primary care network. And we also know that we've got the Greater Manchester vaccination site, which will be based at the Etihad Tennis Centre. Again, that's really great for the city. Still working through the final stage of what will be offered through that GM site, but the priority is to get the PCN sites up and running. And many of you will be aware that the Wave 1 PCN site for Manchester will be in Wythenshawe. Again, final stage of the process just to get everything sorted to hopefully commence the programme at the beginning of next week. And we have put in plans to have other sites in other parts of the city to be Wave 3 sites, which will operate from the 21st of December. Yes, there'll be a focus on the over 80s. You'll have seen that on the media, care home staff, and we're looking at the transport issues and the logistics to support staff to access the vaccine. And you'll also be aware that we've got the hospital rollout programme now. A slight error on this slide. It's the whole of MFT in tranche 2. I just confirmed that with Cheryl Lenny, the chief nurse and their lead this morning. They will be getting their supplies and will commence their programme from next week. And we also know, in terms of the last point on this side, that the Pfizer vaccine, we're all determined that our care home residents get this vaccine as quickly as possible, our most vulnerable group of all. And there are just issues with the way the Pfizer vaccine currently comes. Again, my GP colleagues will be better able to respond to this than me, but we're looking to break that down, I believe, in terms of the supply chain, so it can be used hopefully for mobile use. I think there has to be some further licensing agreements sorted, and that would be a real game changer if we're able to take the vaccine, obviously, to care home residents. We don't want to be seeing care home residents coming out of the safety of those homes into environments where we could increase their risk. Next slide, please. Yeah, and this is my final slide, and just some other bits of information. We know that there'll be a review of the tiers next week, with an announcement expected, we think, on the 16th of December. Both the programmes I've talked about are now part of the 12-point plan, but the information, is so fast changing. We have weekly task groups, and in fact daily meetings now for both of these programmes, just to keep on top of them. But we'll be making sure we communicate effectively with stakeholders going forward, and our comms colleagues across all the organisations have really come together to make sure we do this well in the city. And I think just finally from me, just a recognition and both a call to action to all the people and organisations on the board, but also a thank you for everything you've done so far. But we are going to need all the support of everyone in the city and all organisations for both these major programmes, because they are huge, they are complex, but we know, based on the Our Manchester principles and our way of working, we know we can deliver these for the city. So that concludes the presentation, Andrew. Thank you, and thank you, Chair. Happy to take questions.
There we go. So I can't, for some reason my camera, is it going to work? Yep, it's working. Brilliant. Thanks for that, David. The next item on our agenda is the governance. And clearly you've covered mass vaccination in some detail there. Probably makes sense to take the two together and then just have one discussion. So if there's anything else you want to say about governance for the mass vaccination programme, do so, and then we'll open it up.
Thank you, Chair. No, I think that hopefully the paper's self-explanatory. We've set out the role of the Health and Wellbeing Board, the governance structure for the vaccination programme. It clearly needs through the community cell, both that clinical oversight, and we know all our organisations represented on the Health and Wellbeing Board are on the community cell. We've got the COVID response group that I chair, that I know, for example, Mike's on it from the VCSC, and clearly we've got the SNT Gold. And just to clarify, that does include our LCO partners. Katie attends for the LCO, Ian attends for MHCC, and Jill Heaton for MFT. So good infrastructure of all the partner organisations appropriately represented on the key groups. But hopefully, as I say, the paper's self-explanatory in asking the board to endorse the revised governance. I think you're on mute.
Sorry, yeah, I've just unmuted, sorry. If you want to speak, please use chat, or there is a raise hand facility in the participants list as well. Either of them are perfectly acceptable. Vicky, you wanted to ask a question.
Yeah, just to say thank you for that presentation. Appreciate the scale of the task and the speed at which everything's moving. Just within the 12-point plan, there were a couple of references to dashboards, both one for care homes and one for COVID-19 for the city. Are they publicly available? Can they be accessed by HealthWatch?
David?
So Vicky, we do publish on the council's website every Wednesday the key bits of information we can put in the public domain, but we do have a daily dashboard. I just need to check, I'm being really honest, with Neil Bendel in my team and colleagues at MHCC about the distribution of that dashboard. I'm always comfortable sharing information, but we do put information that's in the public domain on the council website. The dashboard a lot of that is for internal planning purposes. But I will just need to check with Neil Bendel and colleagues about what we could share more widely. And the care homes dashboard, Bernie, did you want to say something about that?
Yeah, so the care homes dashboard gives us valuable information in terms of infections, capacity, staffing. I will check. I don't think there's anything in it, Vicky, that isn't shareable, but like David, I will double check there's nothing in there which is potentially anything confidential to the care home providers. So I'll come back to you on that one.
I think in general that information should be shareable with members of the Health and Wellbeing Board. I think the question will be whether it's being shared on a confidential basis or not. And I think the issue is, which Bernie's alluded to, is that we are quite often not the owners of the data, so we'll need consent of the owners of the data to share it. And have to say, I will say this publicly, if it's NHS England, that permission is quite often not forthcoming in terms of sharing the data. Okay, is there anybody else wants to come in? I've got Mike Wild. Mike.
Thanks, Richard. Thanks, David. That's a far clearer presentation than I've ever seen on national television, so really much appreciated. And as Vicky's just said, thanks for handling the complexity of all this work. I think it's brilliant that Manchester's forging ahead in trying to make sure that people can visit care homes. I just wanted to get a sense of whether you've got a feeling about what the coverage in terms of geographic spread is of care homes that can provide the lateral flow tests, because obviously quite a lot of people might be on public transport and getting to a central point might be difficult.
Again, I'll bring Bernie in because Bernie and I attended a webinar with care home providers, and Bernie's team has also done a ring round of the care homes to check on their readiness for this, and it's a mixed picture as Bernie will highlight. But we are looking, Mike, at what we can do to just make sure people are supported to get to see their loved ones. But Bernie, did you want to come in again?
Yeah, thanks, David. Thanks, Mike. So yeah, we have 90 care homes in the city, and as David said, we held a webinar which was very well attended by the sector. They have a range of issues. They range from very small homes to purpose-built larger homes. Some have very good facilities which will support visiting, will support the lateral flow testing arrangements.
I think we've lost you, Bernie.
Sorry, can you hear me now? I'm not on mute.
I can hear you, Bernie, yeah.
Yeah?
Yes, okay.
Shall I carry on?
Yes, Bernie.
You're on mute, Mike.
Okay, I'll carry on. Please tell me if you start not being able to hear me. We have a range within that 90 home. Within the
Is it just me? I can't hear Bernie. But
No, I think it's just you.
Do you want me to carry on and hopefully you'll be able to hear me as I go on, Chair? I'll carry on. Stop me if everybody else starts not being able to hear me. There are 90 homes of varying sizes, from small, medium, large. Some have got purpose-built facilities, some will struggle. As David has said, we've adopted a blended approach across the 10 localities in GM. Some have adopted doing the lateral flow testing at a community site on behalf of the providers, and some are training up, well, offering the appropriate training to providers to do it. We're doing a blended approach. In Manchester, as ever, we've got a far higher number of providers that we're trying to cover, and we've also got around 3,000 staff. So in terms of the visiting, we're trying to give as much advice and guidance as we can. We're trying to support our sector. We've asked them in the webinar earlier this week how best we can support them. We're getting some very clear comms out to them to complement the national comms. We're getting our Manchester comms out to them. And David and I communicate on a Friday to them weekly in line with our winter plan expectations. We will know more next week, Mike. The lateral flow tests have started to arrive in the homes. They've started to arrive in larger homes across GM, generally when residents of over 50. And we've got about 12 homes on that scale. So we are looking at our coordinating our mobilisation plan with those providers with a range of support that we're offering them. I've finished talking now.
Bernie, I think Richard's logged out and he's going to log back in. So.
Okay. I will just mention then, whilst Richard's doing that, we are really mindful of the high expectations, quite understandably, of families wanting to see their loved ones and the loved ones wanting to see their families. And just to give you our assurance, we're doing everything we can to facilitate that in a safe way as soon as we can.
Well, thanks, Bernie. I'm sad to say that's the only bit I've heard of that, but I'm sure it would have been really good coverage. Is there anybody else wants to come in on COVID? If not, I just want, again, it's a while since we've met as a Health and Wellbeing Board. I want to put on record thanks to health staff, care staff, a whole range of other people that have been providing support. It's clearly been an incredibly difficult 10 months. The last couple of months probably even more so. And whilst the signs at the moment are positive, that I think we know that there are going to be challenges, particularly in January and February, because that is effectively the peak time for particularly for acute services. But again, whilst we tend to look, because they're more visible, at our hospital statistics, I know that primary care has been under tremendous stress as well, and has been really doing remarkably well, again in difficult circumstances. And with the mass vaccination programme in particular, is going to have a busy few months around that as well. So again, a really big thank you to everybody. And also a plea that when we do have a bit of a quiet time, which we might have, that as far as possible, people get some time off, get a bit of a break, because I think it is going to get intense again as we go into the winter. We are asked on item 6 to approve the governance arrangements. The rest is to note, can we approve those governance arrangements? Convention is, I think now on video calls, you take silence as consent, so that's brilliant, thank you. Let's move on then to the Manchester Partnership Board presentation, which I think Ian Williamson is going to introduce.
Thank you, good morning. Andrew, can we have the slide set visible for colleagues? Thank you. Yeah, good morning. I'm going to give a short presentation on progress with integrating health and social care in Manchester and the next steps. Next slide, please. Just start by reflecting on the last 5 years. So 5 years in one slide is a tall order. But just to summarise some of the progress made, we have introduced a number of new integrated, simplified organisational arrangements for the city, as depicted here with a single integrated commissioner, an out-of-hospital provider in the LCO, single hospital service, and a new mental health provider across the city and beyond. All of this aimed to have a clearer set of working arrangements for us in the city, and also a clearer and simpler set of interfaces for patients and residents. Backed up by a number of key plans, particularly our overall locality plan for health and wellbeing and our population health plan that David and his team produce as well. And connected to this as a couple of examples really of the sort of integration that have been going on. Lots of new care models introduced with transformation funding predominantly, trying to ensure that on the ground in neighbourhoods, care and health are joined up as well with other partners as well, including with the VCSE and others. And at the other end of the spectrum, so to speak, a big redevelopment programme for North Manchester, which combines not only a new hospital and other health and care facilities, but also housing and interface with regeneration and redevelopment. Next slide, please. However, there are reasons why this is a good time and the right time to review and reflect and reset for the city. Obviously, we need to build on our successes as described. We also need to learn from our approach to COVID, which has been very good in many ways with more collaborative ways of working. But also we know that some of the our health outcomes are still stubbornly poor, and some of our inequalities have been exacerbated rather than eased by the COVID experience. In terms of our partners and our providers and our colleagues in the city, there have also been some changes. So the introduction of primary care networks, and David has already referenced the work of those in many ways, but in particular now with getting the COVID vaccine off the ground. And I also want to mention the VCSE sector, a well-established and vibrant sector in many ways, but also very fragile and in an increasingly perilous position in some cases, as Mike and I have discussed, and all in the context of real pressures around financial sustainability, a review of the Greater Manchester health and social care arrangements following devolution, and what's now proposed national legislation. As ever with the city, we want to try and anticipate those sorts of changes rather than react to them. Next slide, please. So that sort of review process has involved some independent advice from Mike Farrer, and then some further work by chief executives and others in the city. And we are now in the process of strengthening our local arrangements with a number of examples here. The Manchester Partnership Board is a reshaped Transformation Accountability Board, and we think will be a blueprint for the new local partnership boards, which will need to be in place across not only Greater Manchester, but the rest of England if the new legislation comes into place. A real emphasis, probably a centrepiece of Manchester's next stage will be the supercharging of the MLCO, aim to grow and develop that further to ensure that in neighbourhoods that care and health is as joined up as possible for patients and residents. We're continuing to work through how the clinical and professional leadership arrangements will best work in the city going forward, and also how our financial arrangements can properly support the smooth provision of services. And the GM review is now coming towards its end. So as we look ahead, we need to be preparing certainly for April 22, but probably more importantly in the short term for April 21 as well. Next slide, please. I've referenced the national proposals. On the 26th of November, NHS England launched an engagement exercise which has its overall aims to pursue integration towards better outcomes for populations across the country. The three sort of main organisational proposals in the consultation exercise are the formalising of integrated care systems, in our case, that would mean an ICS for Greater Manchester, and putting that on a statutory footing is the preferred option being proposed. These should be complemented by strong place-based arrangements. I've already referenced the Manchester Partnership Board, and I'll come on to reference the Health and Wellbeing Board as well in that context. And thirdly, the further development really of provider collaboratives that have come to the fore during COVID and now really need to be enshrined formally in the new governance and working arrangements for the NHS, but also with other partners. So that means changes to current arrangements. The CCGs, as we have known them, and some of us have loved them, are almost certainly facing a demise and an end by April 22 at the latest. We are as well needing to enhance our use of data. COVID has been a great example where we've all innovated better in that case, and we need to embed that. And in terms of finance, the next iteration, I think, nationally will be that Greater Manchester will be the place where funds land for the NHS, at least in one pot, probably. And that is likely to be from April next year in many ways. So we will need to adapt in that and ensure that the right flows can happen, for example, between Greater Manchester and Manchester. Next slide, please. So just as encourage the board to just step back from the detail for a moment and think about these changes and what, in a sense, will stay the same and what is changing. We think that the overall collaborative emphasis that we've had in the last few years and the focus on place will absolutely continue, in many ways be strengthened, and the development of the local care organisation in that proactive care is perhaps our best example of that. We do need to keep our eye, obviously, on our financial sustainability and look to maximise that interaction between our clinical, political and managerial skill set. However, there are clear changes with the commissioner-provider split, largely going. A set of other, both local changes, which I've referenced, but also likely national changes, such as the likely abolition of the Competitions and Markets Authority, which has played a part in some ways slowing down or stifling some of the collaboration that we've wanted to pursue previously. And around clinical leadership, a clear shift in primary care towards a greater influence for primary care clinicians, GPs, as providers through PCNs rather than necessarily as commissioners. So headline message is a shift away from competition towards collaboration. So next slide and the final slide, please. So hopefully that's a helpful summary of some of the progress that we have been making. And from the point of view of the Manchester Partnership Board, we will continue to review our arrangements over the next few months based on GM and national changes, based on the emerging plans around clinical leadership, for example, and ongoing dialogue with Health and Wellbeing Board and others. It's important to emphasise that we think that the Health and Wellbeing Board will continue. Those are the indications. So it's really important that as the Manchester Partnership Board will report to the Health and Wellbeing Board, that we consider these sorts of questions over the coming months. So not necessarily in detail for today, but over the coming months. How does the Health and Wellbeing Board and the Manchester Partnership Board work effectively together? Secondly, how will Manchester and our systems work best with the Greater Manchester ICS? What implications might this have for the Health and Wellbeing Board itself in terms of its membership and its role? And in process terms, the final question about how to do this. We've had reviews of the Health and Wellbeing Board in the past, for example, some dialogue and discussion about the best steps for the Health and Wellbeing Board would be useful. Just a final comment then, Richard, which is we're, I think, confident that we can use these changes both in Manchester and further afield to really drive us forward on our next stage of improvements in the city. Thank you.
Thanks, Ian. Questions, comments? Vicky? Do you want to take the presentation down as well, Andrew, please? You're on mute, Vicky.
Okay.
There you go.
One of the main differences between healthcare and social care is that social care is means tested. So as they get integrated, will it still be free delivery to patients at the point at which they're accessing services, and how will that work? Did you hear the earlier part of that, Ian? No, okay, sorry. So the early part of that was, presentation was very organisational, and just from a patient perspective, what will change look like on the ground? And then the point about will it be free at the point of delivery?
Shall I take that, Richard?
Yeah, I think I might want to comment after you, but...
My comments will be yes, in a sense, unapologetically sort of strategic and organisational, if nothing else, to balance the more operational presentations that David has had earlier. In terms of change on the ground, it is sometimes difficult to describe in detail what the immediate impact of some of these strategic changes are, but we can see in our neighbourhood teams closer cooperation between professionals and where it works best, patients, residents receiving care and support in a way that it enhances their freedom and their individuality in a way consistent with the Our Manchester principles, for example. But do we have a simple dashboard for it? I think that's something we will need to continue to work on. And on your second point, what's lacking still so far is any sort of national vision for social care. Unfortunately, so this is a set of NHS proposals that I've been describing. We hear there may be social care proposals, but without those, I think this is not for the first time an incomplete picture. Bernie, I'm sure, for example, would be in a stronger position than I am to comment on social care at the point of delivery. Thanks.
Yeah, I've got a couple more, but I will comment if before I bring Tracy and Mike in. Not only, I think there is a social care absence, there is also a public health absence at the moment as well. So again, it's indicated that there will be proposals coming out from government, not least because of the around the demise of Public Health England and what is going to follow on from Public Health England. So that there is, even within the health and care picture, there is lots of change. But I think from my view, that the NHS England paper, Integrating Care, Next Steps to Building Strong and Effective Integrated Care Systems Across England, although in terms of a lot of what it's talking about organisationally, it's very much about NHS and NHS budgets. A lot of the things it has to say are far wider. So it talks about stronger partnerships in local places between the NHS, local government and others, with a more central role for primary care. It identifies 4 fundamental purposes, and number 1, improving population health and healthcare. Number 2, tackling unequal outcomes and access. Number 3, enhancing productivity and value for money. And then helping the NHS to support broader social and economic development. And perhaps the last one I'll mention from that, and this is also important to our arrangements, although under the new arrangements from an NHS perspective, there will be a single pot GM budget. They also say that decisions about the use of all of these budgets will usually be made at the lowest possible level. So an expectation that a lot of that budget will end up with decisions being made at a neighbourhood level. And going back to, I think, Vicky's question, although this presentation was a very organisational presentation, it was organisational in order to be able to deliver that population health and neighbourhood devolved agenda. And in a sense, we're slightly, well, we are ahead of the game in that we've been putting these arrangements in place in advance of NHS England deciding they want to go down this direction, which I do think puts us in a very strong place, really. The last, I'll say, particularly as Tracy's coming in next, is that Ian referenced in his paper that one of the change areas is around strengthening of clinical leadership roles of primary care. What we're not intending to do is to basically scrap stuff that is working, and I think there's a very strong view that the clinical leadership work that's been going on, that Sahel has been leading on within the city, is something to be enhanced and built on, because I think it's widely recognised across all sectors as being a real strength. So we are going to, as far as possible, avoid throwing out babies with bathwater. Tracy.
Thanks, Richard. I'll try and be brief because we haven't got much time and I'm sure other people want to comment. So we had an LMC meeting last night with a lot of our provider members. So I'm just giving you some feedback from the meeting. Ruth Bromley came to present in the part one part of the meeting, the Commissioner's view. So I'm just going to reference some comments back, and I can do that with more detail, which I have done to yourself, Richard, and to Ian. I can copy him in. So I think there was disappointment that there was no real reference in the last 5 years' work directly to primary care within the slides. But reference were other providers such as MFT, mental health, LCO, etc. So I think GPs have been working really hard on COVID oximetry at home, supporting care homes, flu vaccination, COVID vaccination and many other things, and felt that there was limited reference. They would also like to know more about the function of the partnership rather than its form and its organisation. The function of it should then define those who need to be part of it and would therefore define whether they feel that they need to be part of it because they're not clearly referenced. The LMC wasn't formally included in the Mike Farah piece of work at all, and that just landed in a PCN network that happened to have an LMC rep, but also another rep that was there in the role of federation. And they were interested to see the importance of clinical and professional leadership referenced in there because Ruth expressed her concerns that this would be down to one single space for one person, which then represents over 80 practices, 14 PCNs and over 300 practitioners. So the importance in that, personally, I think you can do it with one person, but it's about the network that sits beneath them and the representation to get that person to really touch base with all the providers in all the spaces, whether they be GP Federation, PCN, individual practice, locums, and wider primary care also. So to ensure that engagement and co-ownership, we really have to have the right structure and form, which we've done obviously in Greater Manchester for a long period of time, and I've been proud of being part of that provider voice into GM partnership, which is inclusive of Federation, LMC and PCN leadership. And I think it needs to reflect some things such as that. Last night the meeting was really wanting the LMC to have a role because the PCN's pieces of work and the PCN DES contract references the LMC as the statutory support organisation for all forms of providers in general practice world. and there was a reference that they prefer it to be more transparent process with the inclusion of the LMC. So just to finish, obviously, you know, the LMC's role is just to get provider representation, to make sure that they stay engaged and feel that all parts of strategy is co-produced. I think we've done marvellous work in Manchester over the last 5 years, and I just want to make sure that any organisational shifts, as you said, Richard, build on the strengths of our collaboration. And I worry a little bit, as did the group last night, about a constant reference over PCNs, which are a structural collaboration between GP practices and may not be here forever. As we know, NHS England turns over lots of their organisational structures regularly. But the practices feel like they want to be engaged as practices, and not just PCNs, but also the wider provider forms. So thank you for that. That was as brief as I could make it.
That's really helpful, Tracy. I'll just say, I hope Ruth contained this within her presentation, because Sahel and Ruth came and presented to the Nascent Partnership Board last week, where we made it clear that in terms of primary care's representation, is that it would be up to primary care to decide how it was going to be represented. It wasn't going to be decided. So in that sense, the ball will be very much in your court. And I'm glad.
That's fabulous, Richard. Thank you.
I'm glad Sahel's put his hand up. I'll take Mike first, and then I'll take Sahel. I was going to call you anyway, Sahel, but Mike.
Thanks, Richard. I'll try and keep it brief because I know we're running out of time. My main question was going to be about community engagement. This seems, as Vicky said, a very system, structure, organisation focused approach. And I know this is the national position. From what I've seen of the national proposals and everything, the idea of citizen involvement, patient engagement and stuff is really barely mentioned. And I wonder whether that's something Manchester as a system could push back on in the response to the consultation about how we see putting patients and citizens at the heart of everything through active involvement. There's been some really good engagement work done by MHCC over the years. We would really need to make sure that actually that moves closer to decision making rather than further away because of the new system. So it's an ask of the whole board, really. Can we feed that back through the national channels?
With your permission, I am going to overrun a little. This is clearly a very important discussion, and I hope you're able to. So we'll try and keep that overrun as brief as possible, although, but I don't really want to cut it off prematurely. Got Sahel and then Bev.
Yes, thank you, Sir Richard. I'll keep it as brief as I can then. So I suppose two things. The piece of work that I was asked to lead was around the sort of locality-wide clinical and professional leadership. Tracy will know that the LMC are part of that group. They've been very engaged and contributed really positively to the review. So I hope she feels that they've been included in that particular piece of work, and we've had formal feedback from them indeed. The other thing, just in the, I can't see Ruth on the invites list, so what I would say, if you'll just permit me to speak on behalf of Ruth for a second, is that when Ruth brought the GP leaders together, she did make a point of inviting the LMC, and I think Simon Minkoff, who's an LMC board member, attended those initial meetings, Tracy. It was a follow-on from that meeting that Ruth was invited to the PCN group that contains those other people you referenced. So I'm sure it wasn't intentional in any way, but she did include LMC board member and was very specific to make sure they could attend before she went ahead with that first meeting. That's all probably that I had to say at that point, Sir Richard.
I don't know if I can just reply to those points. Yes, I'm aware Simon has been involved in some of the conversations. He didn't feel that this was a formal introduction, and nothing came through the LMC office, and I'm not aware that we've made any formal written comment back. This is not to say that it hasn't happened, but it's an important issue of which GPs felt fairly strongly about had been within a PCN construct and not within a practice construct, and they were happy to form themselves into a group that they felt was appropriate, if that's helpful.
Okay. Thanks, Tracy. Councillor Craig.
Thanks, Chair, and apologies again, my camera still isn't working, so I'll have to speak without it. I wasn't going to say much around the primary care component. I think just to echo the strong view of everyone that's involved, that GPs and clinicians have a really important role to play, not just in a new Manchester Partnership Board level, but at every level of the system, and we emphasise that in our discussion. And I think today's discussion has demonstrated the challenge that we have as a system to make sure not just that that's correct, but that's properly articulated to people in terms of how those decisions are being made. But that leads on probably to my other point, which speaks more to what Mike and Vicky raised, in a sense, that I think, you know, you can't get away from the significant national change that is coming structurally. But I suppose what comes through for me in this presentation is indeed how we use that to continue the path that we've set ourselves on in Manchester. And for me, you know, it's about making sure we retain the best bits of what NHSE does in terms of, particularly your point around engagement, work with not just patients, but people where they live, not just where they go to get services. And I think the real strength in some of the work that's been done around thinking through the supercharging of the LCO, for me, is really where it's at when it comes to people in place having a voice in local services. So it's just to offer some reassurance, particularly to Mike's point, that's at the heart of what we're trying to do, and will feature in the system response to any national consultations that's been carried out, not just in terms of this, but also public health and social care.
Okay, can I just Ruth Bromley has sent her apologies for the meeting, so that's why she's not here today. I think it's also worth noting that the NHS paper was described as an engagement paper. It's not a consultation paper, and I think it's pretty much a paper that tells us this is what we're proposing to do, get ready for it. So I think it has to be read in that light. Dennis, you wanted to come in. Need to unmute, Dennis.
Thanks, Richard. Yeah, it just took me a minute to unmute there. I guess I'm echoing what's been said already, but in a slightly different way. And I'm thinking back to some of the work that I've been involved in the past few years, which is the citywide palliative care service, which was developed along with Macmillan. And I'm just struggling to think that if we had the arrangements as described, how we would get that up and running across the city, because I think PCNs are not the model for everything. And in terms of place-based care, I'm completely on board with that, but some things need to take place across the city, and I'm not quite sure how the new system would work that way. Maybe I'm just not understanding it correctly. And the other thing is, and I think Mike's already made the point, but I'll make it again, in relation to Macmillan, we had a lot of co-development with patients, and patients being represented, you know, kind of every step along the way where that was appropriate. And again, I'd just like to say that from what I can see, and clearly we're not seeing everything today, there does seem to be a gap for patients to hear their voice or to have their voice heard. The 2 points I wanted to make.
Okay, thanks for that, Dennis. Apart from anything else, we're not proposing any changes to how patients' voice will be heard, and I don't think NHS are at the moment, although if we get our neighbourhood arrangements right, then there ought to be a strengthened voice. And it's also worth bearing in mind that this is not just it's not just about patients. In fact, a lot of this is about people not becoming patients rather than patients, and I think that's really important to remind ourselves of that. I think in terms of your point about really hierarchies of commissioning, the starting point for me will be an assumption that if we can commission at a neighbourhood level, we do, effectively. If there are things that need to be commissioned at a citywide level, we do that. And in some cases, of course, we'll be commissioning at a Greater Manchester or even above Greater Manchester level. But the starting point is you start small and you have to make the case for being bigger, not the other way round. And I think the example you gave is something that will still be commissioned at a citywide level because the case is there for doing it at that level. I'm going to ask Ian to really come back now, and there's nobody else indicated. So I'm going to take this as the last contribution. Ian.
Yeah, thanks, Richard. Just really helpful conversation and comments. Thank you. We'll take that away as part of our ongoing work on all of this. Just to say, I think Ruth, I think it's her birthday today, and I think she's on leave today. So that's why she's not here. Absolutely recognise the valuable role of GPs as yourself and Bev and others have described, and pivotal role in everything that we do going forward, along with other clinicians and professionals across the city. And again, just to thank Mike for his comments about the work of MHCC. The Health and Wellbeing Board might be interested to know that on the latest league table ratings for CCGs across the country on public and patient engagement, that Manchester Health and Care Commissioning achieved the highest possible rating, a green star rating, for the second consecutive year. So yes, hopefully we can take some of that forward into our next iteration of organisations. Many thanks.
Thanks for that. And I think as a Health and Wellbeing Board, we ought to congratulate you and your colleagues, Ian, for that. That's brilliant. So well done, and please pass that back. I think it's appalling that Ruth does not think the Health and Wellbeing Board is a good way of celebrating her birthday, not least because it's missed the opportunity for us to do a Zoom singing of Happy Birthday, which if you've ever done it, you'll know is something you don't want to hear too often, to be honest. But but we can wish Ruth a happy birthday anyway. This is to note at the moment, this clearly is still, although the partnership board is meeting, it is still very much work in progress. It's and clearly work in progress that will continue, I think, for a period of time because we are looking for the next 5 years, not just for the next few weeks. And the comments are really, really helpful and very much appreciated. Told that the Strategic Director of Children's Services is giving evidence at a select committee today, and on that basis I propose that we defer the children's plan to our next meeting. And I think, and the screen I've got the agenda on has gone off, so I can't see the agenda anymore, but I think that brings us to the end of our meeting, in which case can I thank all of you very much for attending, and particularly as we have overrun a little bit, and look forward to seeing you all soon. And we are getting close enough, I think, now to also hope that people both get a break over the Christmas New Year period, but also do not cause a health crisis as a consequence of having that break. Thanks very much, everybody. See you soon.
Thank you, Chair.
Thanks.
Thank you. Thank you.